top 2/3 of the epidermis, so they haven't become a full-fledged squamous cell cancer yet. So squamous cell cancer is cancer of the keratinizing cells of the body. That's less common than basal cells. It's about 5 to 10% of patients. There's about a 5% risk of metastasis. And the areas that are more likely to metastasize, although those risks are, like I said, very low, are the ears and the lips. So they affect the mucous membranes. And then there's melanoma, which is the one that we all hear about. So melanoma is responsible for 1% of all cancer deaths yearly. 1 out of 5 patients will develop a skin cancer in their lifetime, and melanoma is the one that we know is deadly. What I really don't believe in is the ABCs. So just take a look at the backtrack and look at some photos here. This is nodular basal cell here. As you can see, it's a pearly papule. It looks innocent enough, but they tend to have little blood vessels in them because cancers need to grow. The second photo is of the basal cell actually has color because we're all educated that they're clear or they can be possibly a little reddish, but there's a variation that's less common called pigmented basal cell. And then the third is a superficial basal cell. Some of those can be treated with topical creams. They just look like a rash. They're the easiest to treat. They haven't gone past just the top portion of the epidermis. It hasn't gone into the dermis. So it's the best of the best. So next, squamous cell. We talked about actinic keratosis with the atypia, abnormal cells in the top 2/3 of the epidermis, and about 10% of those can evolve into a squamous cell. But I look at everything as a spectrum. So you have precancer or actinic keratoses. Then you develop something called squamous cell in situ, which is a localized skin cancer to the epidermis. It's full thickness atypia. So instead of 2/3 of the epidermis with the precancer, it's full thickness. But it has not involved the dermis or subcu. And then the second picture shows squamous cell, a full-fledged squamous cell, which has involved the dermis or subcu. And how do we treat these? Well, moving back, basal cells and squamous cells, both of them need to be treated. They grow locally or in rare cases can metastasize or erode into structures. You can treat, but depending on the subtype, superficial basal cell can be treated with a topical cream. Otherwise, you can treat with excision or Mohs, which is tissue sparing, whichever is appropriate for the patient based on the location and histology. Is it poorly differentiated, well differentiated? Again, the biopsy is the gold standard to start with. And then we come to melanoma. So melanoma, it's important to know when we talk about the ABCDs of melanoma, asymmetry, border, jagged border, color, diameter larger than a pencil eraser, which is about 6 millimeters. And that can give you false concern and false reassurance. So it's very important that whoever's taking a look at the patient, they could be scared from a seborrheic keratosis, which almost looks the same as a melanoma to patients. Just because it's raised or it has some pigment is not necessarily, do or die. So these are just some examples of melanoma. There's several subtypes of melanoma. In my practice, we pray that we can catch it in the in situ stage, so it's still within the epidermis, and we can treat it with local anesthesia and avoid oncology. But there is other